everyone, this is our lecture on complement disorders. So let's get started. Here, in all of its glory, is the overall complement cascade. Deficiencies of various aspects of the complement cascade are fairly high-yield topics, and we can organize them by complement protein deficiencies and complement regulatory protein deficiencies. The complement protein deficiencies are a problem with the individual complement proteins themselves. And we can further organize them by early complement protein deficiencies and terminal complement protein deficiencies. Regulatory proteins also exist, so that complement doesn't get out of hand and start attacking our own self cells. But these can become deficient too. So let's first talk about the early complement protein deficiencies. So the left side of the mega image on the last slide, as you can see here. Complement proteins are mostly named with the letter C, some number 1 through 9, and sometimes with an A or B attached too. So if we're going to talk about the early deficiencies, we're looking at C1 through C4. Now, what's the whole point of complement anyway? It's part of our innate immune system, and it helps with the inflammatory response. It has 3 pathways that get activated by antigen-antibody complexes, like in the classic pathway, by microbial surfaces, like in the lectin pathway, or even spontaneously to get rid of bacteria, like in the alternative pathway. They get activated in the beginning to start off the cascade with interaction with our early complement proteins. So what do you think would happen if one of these early complement proteins is deficient? You're right if you said severe and recurrent sinus infections and respiratory tract infections. Now, what about specifically those immune complexes? Well, you better believe that if we can't react to them, we'll also have an increased risk of SLE. Now, onward to the terminal complement protein deficiencies. So the right side of the mega image, as you can see here. The terminal complement proteins are C5 through C9. And can you remember what those complement components are needed for? Yes, they're needed to make MAC, or the membrane attack complex. If we're missing any part of the membrane attack complex, it messes up our innate defense against gram-negative bacteria. Can you tell me what the arrow is pointing to in this image? You're right if you're saying it looks like a gram-negative diplococci. What organism comes to mind? Yep, so when we are missing a terminal complement protein, any piece of C5 through C9, this increases our susceptibility to recurrent infections with Neisseria. Now in this image, we can see petechial hemorrhages and gangrene of the toes, which can be caused by Neisseria meningitidis. Now, let's move on to the regulatory protein deficiencies. The first of which we'll talk about is C1 esterase inhibitor deficiency. C1 esterase inhibitor functions to prevent C1 from allowing the conversion of C2 to C2b and allowing the remainder of the complement cascade to continue. However, another pathway to consider that is closely linked to complement is the activation of bradykinin. Now, if you recall, bradykinin is an inflammatory mediator, and it causes vasodilation, permeability, and pain. So if we have a deficiency in C1 esterase inhibitor, this pathway can get a little out of control, and it can lead to a condition known as hereditary angioedema. In this image, you can see the inflammation and how because of increases in permeability due to bradykinin, there is characteristic swelling around his eyes. All in all, with a deficiency in C1 esterase inhibitor, it leads to unregulated activation of kallikrein, which leads to increased levels of bradykinin. This is also a decrease in C4 levels. This is a good time to revisit the renin-angiotensin-aldosterone system, and when you do, you'll recognize that ACE inhibitors are contraindicated in this condition because it will further increase bradykinin. Now, another one of our regulatory protein deficiencies results in a condition known as paroxysmal nocturnal hemoglobinuria. What happens is there's an acquired mutation in the PIGA gene, which prevents the formation of GPI, which is responsible for anchoring two of our complement inhibitors, CD55 and CD59, also known as decay accelerating factor and the membrane inhibitor of reactive lysis, or MERL. So now we can't be protected from complement. Well, what happens when we don't have the inhibitor of lysis? Well, the cells will lyse. This leads to complement-mediated intravascular hemolysis, which will lyse our red blood cells and lead to a decrease in our haptoglobin. Overnight, the cells get lysed a lot, and when the person wakes up, the urine is very dark compared to normal from the hemoglobinuria, as you can see in this image. Addition is also associated with aplastic anemia and leads to an increased incidence of acute leukemias. It also presents with a triad. Do you know what the components are? You're right if you said that someone with PNH or paroxysmal nocturnal hemoglobinuria would have a Coombs negative hemolytic anemia, pancytopenia, and venous thrombosis. There is a therapy for it, and do you know what it is? It's the drug eculizumab, which targets C5 to prevent MAC from forming and more cell lysis. Alright, that's all I have for you here. Thanks for joining me. Please give this video a thumbs up if you liked it, and it'll give you the opportunity to submit a comment if you have any feedback or questions. Thanks again. Study hard. Hi everyone, this is our lecture on important cytokines. This is a high-yield topic that will come up again and again on important tests throughout your career. Now, cells communicate through cytokines. Interleukins are types of cytokines that we'll talk about now. Let's first break down the word interleukin, which means between white cells, which makes sense since they're the means by which white blood cells communicate with each other. And we can further classify the different interleukins by where they come from. And in this video, we'll talk about the interleukins secreted by macrophages and T cells. So first, let's talk about the interleukins secreted by macrophages. And those include interleukin 1 and interleukin 6. We'll talk about a few more secreted by macrophages on the next slide. So when you think about fever and acute inflammation, IL-1 and IL-6 should immediately come to mind. IL-1 also activates the endothelium to express adhesion molecules. Oh man, where did you learn about the adhesion molecules? There must be a reason for the big gap on the bottom of this slide. Well, you're right if this image comes to mind. Remember, when white blood cells exit from blood vessels at sites of tissue injury and inflammation, the second step involves tight binding to the endothelium, which requires the endothelium to express adhesion molecules, like ICAM in the picture. It's right in the middle of the picture. Now, IL-1 also induces chemokine secretion to recruit white blood cells, which makes sense because inflammation is going on. IL-1 is also known as osteoclast activating factor. Do you remember what we need the osteoclasts for? We need osteoclasts in bone formation, especially in endochondral ossification, to replace the cartilaginous model of bone with woven bone, which later becomes lamellar bone. Osteoclasts secrete hydrogen ions and collagens to dissolve bone. Now, can you tell me what this radiograph is showing? You're right if you said it's osteopetrosis. This is when there's a failure of normal bone resorption due to defective osteoclasts, leading to thickened, dense bones that are prone to fracture. Now, one more thing about IL-6. It also stimulates the production of acute phase proteins. Now, I know that's a lot of information, and we've only really looked at 2 of the cytokines. But a really, really, really helpful mnemonic is hot T-bone steak. IL-1, like we've already talked about, causes fever, so it's hot. IL-2, which we'll talk about in a little bit, stimulates T cells. IL-3 stimulates the bone marrow. IL-4 stimulates IgE production. IL-5 stimulates IgA production. And IL-6, again, stimulates acute phase proteins. So keep all this in mind as we discuss some more. Now, we've got a couple more to talk about that are secreted by macrophages. First, we've got tumor necrosis factor alpha. It activates the endothelium and causes white blood cell recruitment and vascular leak. Tumor necrosis factor alpha is what actually causes cachexia in malignancy. You can just think of the name. Tumor should remind you of cancer, and necrosis is a type of cell death. And cachexia just brings the image to mind of wasting away. Okay, I know we say this a lot, but the next point is pretty high yield. TNF-alpha maintains granulomas in tuberculosis. And lastly, TNF-alpha, along with IL-1 and IL-6, all mediate fever and sepsis. Next up is interleukin-8, which is a major chemotactic factor for neutrophils. Can you remember the other important chemotactic factors? You're right if you said C5a from complement, leukotriene B4, kallikrein, and platelet activating factor. A great way to remember IL-8 is clean up on IL-8. IL-8 kind of sounds like IL-8, and we need those neutrophils to help us clear infections. Last for this slide, let's talk about IL-12. IL-12 induces the differentiation of T cells into Th1 cells and activates natural killer cells. So now that we've talked about a couple important cytokines, a great summary for where we're at right now is to say acute, then recruit, because it rhymes and it's fun to say. So what comes on acutely to cause fever? It's IL-1, IL-6, and TNF-alpha. And then what comes by to recruit neutrophils and natural killer cells? That's IL-8 and IL-12. Now, let's get to talking about the interleukins secreted by all of the T cells. First up is interleukin-2. IL-2 stimulates growth of helper, cytotoxic, and regulatory T cells, and also the natural killer cells. It calls for more help. Next up, we have interleukin-3. IL-3 supports the growth and differentiation of bone marrow stem cells and functions, just like GM-CSF. Well, what does GM-CSF stand for? You're right if you said granulocyte. So in this image, we've got granulocytopoiesis. Macrophage. So here we've got monocytopoiesis and macrophages. So it's a granulocyte macrophage colony stimulating factor. So here in this image, we have the overview of hematopoiesis and what GM-CSF helps to do. Now here's another image. Can you identify what it is? There's a lot of fatty infiltration here. So this is aplastic anemia. Aplastic anemia is caused by failure or destruction of our hematopoietic stem cells, and patients with it can benefit from bone marrow stimulation with GM-CSF. Fun fact, there's also a drug made as a recombinant GM-CSF. Do you know what it's called? It's sargramostim. So it's sargramostim, sargramostim. And this is useful for leukopenia or low white blood cells. And specifically, it's good for the recovery of granulocyte and monocyte counts. Now, specifically from Th1 cells, we have interferon gamma. Interferon gamma is secreted by natural killer cells and T cells in response to antigen, or from IL-12 from macrophages. It stimulates our macrophages to kill phagocytosed pathogens. Now, here in this image, we can see the differentiation of T cells, and over on the right, we can see that Th1 is stimulated by interferon gamma and IL-12. But it also secretes interferon gamma in a positive feedback manner. Underneath that, you can see that interferon gamma also inhibits the differentiation of Th2 cells. Additionally, it also activates natural killer cells to kill virus-infected cells and increases MHC expression and antigen presentation by all cells. Now, since we've covered the ones from the Th1 cells, it's only fair that we talk about the interleukins from the Th2 cells. First up is interleukin 4. Do you remember what IL-4 is from hot T-bone steak? It's the E. So interleukin 4 induces the differentiation of T cells into Th2 cells, promotes the growth of B cells, and enhances class switching to IgE and IgG. And a mnemonic to help you remember that is ain't too proud to beg for help. So remember that 2 is for Th2, it promotes B cells, and helps class switching to IgE and IgG for beg, and it's interleukin 4. Now we have interleukin 5. Interleukin 5 promotes growth and differentiation of B cells. It also enhances class switching to IgA and stimulates the growth and differentiation of eosinophils. Can you remember some causes of eosinophilia? You're right if you remember the mnemonic NAACP. So, neoplasia, asthma, allergic processes, chronic adrenal insufficiency, and invasive parasites. Now last, but certainly not least, we have interleukin 10. Interleukin 10 is one of our regulators. Here's a close-up of the image from the last slide, and you can see that IL-10 actually inhibits our Th1 cell production. So IL-10 attenuates the inflammatory response. It also decreases expression of MHC class II and the Th1 cytokines. It inhibits activated macrophages and dendritic cells, and it is secreted by our regulatory T cells. A way to remember two that go together is that transforming growth factor beta and IL-10 attenuate the immune response. So the B in both beta and the 10 in IL-10, and they attenuate. All right, I know that was a pretty long video, but that's all I have for you here. Thanks for joining me. Please give this video a thumbs up if you liked it, and it will give you the opportunity to submit a comment if you have any feedback or questions. Thanks again. Study hard. Hi everyone. Welcome to our lecture on the respiratory burst. Let's get started. Let's start off with this flash case. Let's say a 16-year-old male is brought to the clinic by his parents due to a week of fever, cough, and hemoptysis. He was recently adopted. Bronchoalveolar lavage with biopsy reveals fungus, with septate hyphae branching at acute angles. The patient states that he experienced similar symptoms last year. What's the most likely diagnosis? Is there an immunodeficiency that this patient could have? Let's keep this case in mind as we go through the lecture. Our learning objectives are to explain the respiratory burst and its role in the immune response, and to list the enzymatic reactions that occur in the respiratory burst, and to associate clinical findings with the respiratory burst. Okay, so what is the respiratory burst? It is also called the oxidative burst, and it involves the activation of the phagocyte NADPH oxidase complex, which is in neutrophils and monocytes, which utilizes oxygen as a substrate. This makes sense because when we talk about respiration, what comes to mind? I hope you're saying breathing. When we talk about breathing, why do we breathe? We're trying to take in oxygen and release carbon dioxide. So this respiratory burst needs oxygen as a substrate. When we talk about phagocytes, what comes to mind? What are phagocytes for? I hope this image comes to mind. Our phagocytes engulf bacteria and other small particles to remove debris and pathogens. Our phagocytes include neutrophils, macrophages, and monocytes. What process should come to mind when you think of those cell types? I hope you're thinking of inflammation. Remember, these cells and the respiratory burst play an important role in the immune response through the rapid release of reactive oxygen species, or ROS. As we're about to see, NADPH plays a role in both the creation and the neutralization of reactive oxygen species. So, let's talk about this process. Let's say there is this bacteria hanging around, just outside our neutrophil cell membrane. With the process of phagocytosis, remember that the microbe has to be recognized by the phagocyte, then bind to a phagocyte receptor, and then eventually it gets engulfed by the phagocyte, so now it's over here. The plasma membrane will pinch off to form a vesicle, or a phagosome, around the particle to enclose it. And when this phagosome fuses with a lysosomal granule, it is called a phagolysosome. The whole purpose of this is to get this microbe to degrade, like this. So, first, what needs to occur? We need something as a substrate. Can you remember what we said it was on the last slide? Think of respiration. Yep, it's oxygen. So we need oxygen to start things off. The first enzyme we need is NADPH oxidase to convert NADPH to NADP+ to form the superoxide anion, like this. Superoxide is highly reactive, and we use the enzyme superoxide dismutase to convert it to hydrogen peroxide, or H2O2. Hydrogen peroxide can then be broken down into water and oxygen by bacterial catalase, or it can be used to generate water and oxidized glutathione with catalase and glutathione peroxidase, which can be used to form NADP+ to power some of our metabolic pathways with the enzyme glutathione reductase, which can turn glucose 6-phosphate to 6-phosphogluconolactone with the enzyme G6PD, or glucose 6-phosphate dehydrogenase. Or hydrogen peroxide with a chloride ion can be converted to hypochlorite, or bleach, with the enzyme myeloperoxidase. I know that was a lot of information, but there are some very interesting clinical correlates with the whole mechanism. Myeloperoxidase contains a blue-green, heme-containing pigment that gives sputum its color. If you ever have a bacterial infection and your phlegm looks greenish, you can blame myeloperoxidase. Phagocytes of patients with chronic granulomatous disease, or CGD, can utilize hydrogen peroxide generated by invading organisms and convert it to reactive oxygen species. Why is this important? Because remember, patients with chronic granulomatous disease are missing what enzyme? Yep, it's NADPH oxidase, which was the first enzyme we saw in the last slide. CGD patients are at increased risk for infection by catalase-positive species, like Staph aureus or Aspergillus, because those species are capable of neutralizing their own hydrogen peroxide, leaving phagocytes without reactive oxygen species for fighting infections.
People with CGD have recurrent infections with certain catalase-positive organisms. Can you name some? You're right if you're thinking of Nocardia, Staph, Serratia, Candida, Listeria, E. coli, Aspergillus, and more. One of those catalase-positive species, Pseudomonas, has piocyanin that generates reactive oxygen species to kill competing pathogens. In addition, the oxidative burst also leads to potassium influx, which releases lysosomal enzymes. Lactoferrin is a protein found in secretory fluids and neutrophils that inhibits microbial growth via iron chelation. I know that was a lot, so let's do a quick flash quiz to recap. What is the first enzyme involved in the respiratory burst that is also deficient in patients with chronic granulomatous disease? Yep, it's NADPH oxidase. So let's revisit our case. We have someone with fever, cough, hemoptysis, and fungus with septate hyphae branching at acute angles. And he had a similar presentation last year. Which fungus should come to mind when we talk about acute angles? Yep, you're right if you're saying Aspergillus. Remember, Aspergillus is one of our catalase-positive organisms, so people with chronic granulomatous disease or NADPH oxidase deficiency can have recurrent infections. These organisms can neutralize their own hydrogen peroxide, so the phagocytes end up without the reactive oxygen species needed for fighting infections. What's the bottom line? The respiratory burst plays an important role in immune response because of its rapid release of reactive oxygen species to help fight infections. Also, patients with chronic granulomatous disease are deficient in NADPH oxidase and are at increased risk for infection by catalase-positive species. Well, that's all I have for you here. Please give this video a thumbs up if you liked it, and it'll give you the opportunity to submit a comment if you have any feedback or questions. Thanks for joining me. Study hard.
Hi everyone, this is our video on interferons. Let's get started. So let's say a virus, like this one, comes across a human cell, like this one, and then it binds to a receptor on the surface, like this. And it eventually gets endocytosed, like this, then replication, protein synthesis, and assembly, and then it gets released to infect all the other cells. Well, how can we stop this rampage by the virus? You may recall some drugs that interfere with the replication part, like acyclovir, foscarnet, or ribavirin. You may have even heard of drugs that interfere with the release of the virus. Can you remember what an example is? Of the neuraminidase inhibitors like oseltamivir for influenza. But those are all drugs. We're here to talk about interferons. Interferons are a part of our innate host defense. So they're built in. And they interfere with both RNA and DNA viruses. So when the virus comes along and infects a cell, the human cell doesn't just stand idly by getting affected, it reacts. It synthesizes interferons. They're glycoproteins, and they're warning signals for all the other cells nearby. The interferons get released to tell the local cells, hey, you need to protect yourself. There's a virus in me. What can the uninfected cells do when they get the message? They can do two things with interferons. They can try to turn off their protein synthesis, so if a virus does infect them, the virus won't be able to hijack its system and replicate. They can also send out more scouts to the surface to recognize if a bad guy is coming. Or in the case of our cells, they can upregulate MHC expression. So that's exactly what's written here on the slide, just less technically speaking. Interferons play a huge role in activating anti-tumor immunity. In this diagram, we can see that's what interferon alpha is doing here. It's interacting with a receptor to downregulate protein synthesis. Now, the interferons have a number of clinical uses. Let's see if you can name a few. What do we see here in this image? Well, they are dark, violaceous nodules. You're right if you said Kaposi sarcoma. Kaposi sarcoma is a neoplasm of endothelial cells caused by human herpes virus 8. And it's most commonly seen in HIV or AIDS and transplant patients. Now, how about this image? These cells almost have hair-like extensions to them. You're right if you said it's hairy cell leukemia. What can you see in this radiograph? Well, it's pointing to the kidney. Can you recall what is the most common primary renal malignancy? It's renal cell carcinoma. Bonus points if you can tell me what the most common subtype of renal cell carcinoma is. Oh, wait a second. Did you say clear cell? Because clear cell is the answer. Anyway, what can we see in this image? Well, it seems like there are periventricular plaques, and they're actually representative of areas of oligodendrocyte loss and reactive gliosis. Yep, you're right if you said multiple sclerosis. Now finally, what do we have here? It kind of makes me want to sing the alphabet. A, B, C, D, E. What do these letters stand for? So A stands for asymmetry. B for border irregularity. C for color variation. D for a diameter greater than 6 millimeters. And E for evolution over time. These are bad signs and could be indicative of malignant melanoma. This one in particular is an image of the superficial spreading type. Now, those are already a lot of good clinical uses for the interferons, but they are also useful for chronic hepatitis B and C, condyloma acuminatum, which I've spared you a picture of, and chronic granulomatous disease. Now, due to advances in research and technology, we're learning more and more about medicine every day. And there are more options available today to treat or to alleviate the conditions on the previous slide, which don't have as many adverse effects. Now, some of the adverse effects of the interferons include flu-like symptoms, depression, neutropenia, myopathy, and interferon-induced autoimmunity. And that's because the interferons are essentially activating the inflammatory response in order to fight off whatever infection they are attacking, and it more or less drains the body. Now, although this is not as frequently used as it was in the past, the mechanism for interferons is still a hot topic for the USMLE. All right, that's all I have for you here. Thanks for joining me. Please give this video a thumbs up if you liked it, and it will give you the opportunity to submit a comment if you have any feedback or questions. Thanks again. Study hard. Hi everyone, this is our video on cell surface proteins. Let's get started. Now let's start off with discussing the cell surface proteins on our T cells. Just as a review, remember that T cells mediate our cellular immune response. They originate from stem cells in the bone marrow, but they mature in the thymus. Now, what are the different subtypes of T cells? You're right if you said the helper T cells, the cytotoxic T cells, and the regulatory T cells. Now, let's talk about the proteins on the surface of all types of T cells first. So, as you can see in the two images on the left and in the middle underneath this chart, a T cell has a TCR, or a T cell receptor, on its surface, and this is what binds the antigen MHC complex from the antigen-presenting cells, like dendritic cells and B cells. Now, over on the right side, you can see that CD3 is also on the surface of all T cells. It's associated with the T cell receptor for signal transduction. Now, also on all of our T cells is CD28, which is shown in blue on the image on the left. You can see it over here. It's a co-stimulatory signal that we need for T cell activation. It binds with B7 on the antigen-presenting cell. Now, let's talk about helper T cells. Helper T cells express CD4 on their surfaces, and this is to recognize MHC2. They also express CD40 ligand, as you can see in the teal color in the middle image. Now, helper T cells also have the cell surface receptors CXCR4 and CCR5, which are co-receptors for HIV. CXCR4 is on the T cells in late HIV infection, while CCR5 is actually often on macrophages in early HIV infection. Now, can you remember what effect a mutation of CCR5 means in HIV? You're right if you said that a homozygous mutation would result in immunity, and a heterozygous mutation would result in a slower course of the disease. Great job. Next up are the cytotoxic T cells. What do they need to express on their surfaces to recognize MHC1? You're right if you said CD8. Now, lastly for this slide, let's talk about the regulatory T cells. They have CD4 and CD25 on their surface. Now let's talk about the B cells. While our T cells were mediating our cellular immune response, our B cells were mediating our humoral immune response. They also originate from stem cells in the bone marrow, but they mature in the marrow too. Then they move on over to peripheral lymph tissues, like the lymph node follicles and white pulp of the spleen. When B cells meet up with an antigen, they differentiate into plasma cells, which make antibodies and memory cells. So what do the B cells need on their surfaces? Well, they need an immunoglobulin to bind to the antigen, and they have CD19, 20, and 21, which you can see in the image on the right. This is pretty great because it's easy to remember because the numbers are all in order, 19, 20, 21. CD21 in particular is the receptor for the Epstein-Barr virus, and our mnemonic for that is you must be 21 to drink beer in a bar. Well, what's next? So we saw CD40 ligand on the T helper cell on the last slide, and here we see down below on the left that CD40 ligand is binding to CD40 on the B cell. Now, since B cells can be antigen-presenting cells, it will present that antigen using MHC2, and it has B7 for a co-stimulatory signal. Now, let's talk about macrophages. Down below, you can see a nice microscopic image of a macrophage. What do macrophages do? Yep, they clean up. They phagocytose bacteria, cellular debris, and our old senescent red blood cells. So they need a couple surface proteins to do their job. So CD14 is their receptor for PAMPs. And what are PAMPs? Those are the pathogen-associated molecular patterns, and those are what activate our immune response. What PAMP comes to mind? Maybe because it's already on the slide. Yeah, it's LPS, or lipopolysaccharides, the endotoxins found on cell membranes of gram-negative bacteria. Actually, to go a step further, when lipid A from LPS binds the CD14 on macrophages, this is what initiates septic shock. Alright, what else? So just like our friend the B cell, macrophages can also be antigen-presenting cells, so they'll also have MHC2 and B7. And they'll also have CD40 to bind to CD40 ligand on the helper T cells. Now, as I mentioned a bit earlier when we talked about the helper T cells, CCR5 is often on macrophages in an early HIV infection. Now lastly, we also have our Fc receptor for antibodies and C3b for enhanced phagocytosis. What's that term for enhanced phagocytosis? Yes, it's opsonization. Now, let's take a break and do a little cell type recall. Macrophages are special because they aren't called macrophages everywhere. The name is different with tissue types. Can you fill in the blanks with what macrophages are called in the liver, the connective tissue, the skin, the bone, and the brain? I'll give you a second. All right, you're right if you said Kupffer cells, histiocytes, Langerhans cells, osteoclasts, and microglial cells. Awesome. Okay, we're on the home stretch, friends. Hang in tight. What about our natural killer cells? What are they for? We need them as a part of our innate immunity, especially against intracellular pathogens. They've got those cytoplasmic lytic granules with the perforin and granzymes that can induce apoptosis in target cells. The cell surface proteins here are CD16 for the Fc of IgG to bind to, and CD56, which is more or less a marker for NK cells. And lastly, we've got our hematopoietic stem cells. Here's the overall picture of hematopoiesis for you to look over, but what I want you to know for this lecture is that our hematopoietic stem cells have CD34 on their surface. All right, that's all I have for you here. Please give this video a thumbs up if you liked it, and it will give you the opportunity to submit a comment if you have any feedback or questions. Thanks for joining me. Study hard.
Anergy refers to the state in which immune cells become non-reactive after encountering one type of stimulatory molecule without also encountering the appropriate co-stimulator. What? Okay, so here we have an antigen-presenting cell, and here we have a T cell. But notice that this T cell is lacking its surface protein. Without this protein, the second signal is not made, and activation will not occur. Why do you think this concept would be important? This prevents massive inappropriate immune activation, which could lead to inadvertent harm to our bodies. It's like trying to launch a nuclear missile, and you need 2 secret key cards in order to activate it. In Anergy, you only have one of the key cards, and so there is no way to be able to get the desired result without that second key. While we've already split the immune system into the innate and adaptive categories, it can also be divided into both a passive and an active arm. Passive immunity is the quicker of the two to act. It relies on the acquisition of pre-formed antibodies, such as through breast milk in the newborn, or the injection of antitoxins or humanized monoclonal antibodies. Unfortunately, it has a short half-life of only about 3 weeks. Nevertheless, physicians make use of this principle when administering pre-formed antibodies that treat several diseases, including tetanus, botulism, Hep B, varicella, and rabies. You can remember the mnemonic, "to be healed very rapidly," to remember all of the antibodies that are given in passive immunity. The active arm works a little differently. Despite the name, it's actually the slower of the two to act. Active immunity to a specific antigen comes about after an organism has been exposed to that antigen for the first time, usually through direct infection. exposure to a toxoid, or a vaccine. Active immunity and memory occur via thymus-dependent mechanisms through presenting protein antigens and then co-stimulation. The active immunity arm is obviously then going to be longer lasting. Both the passive and active arms can be given in Hep B and rabies infections.
Hey everyone, this is the lecture on vaccination. So let's get started. First up, what is a vaccination? Why are they so important? A vaccination is made up of antigenic material. When you think of an antigen, what do you think of? It could be from a foreign particle, like outer membrane proteins from a bacteria, or it could be a toxin, like the various exotoxins and endotoxins. So, when we administer a vaccine with antigenic material, what happens? Well, our bodies recognize that something that isn't supposed to be around is now in our system, and our immune response gets stimulated. It actually induces an active immune response, which could be humoral, cellular, or both, to specific pathogens. Now, vaccines help to prevent disease, often before exposure or sometimes even after exposure, to prevent the disease from causing its effects on the body. Now, here are some images of diseases. Can you recognize them? The first one is, it's measles, which usually starts off with a fever, cough, coryza, which is irritation of the upper respiratory tract, and conjunctivitis. And 1 to 2 days later, there's a maculopapular rash that you can see here that starts at the head and neck and spreads down. Now, in the second image, we see parotitis, which is inflammation of our parotid glands, which can show up with orchitis, aseptic meningitis, and pancreatitis, and this is due to a mumps viral infection. And lastly, we see rubella. This maculopapular rash also starts on the face and spreads to involve the trunk and the extremities. Now, one type of vaccination is the live attenuated vaccination, which involves the injection of viral particles that have lost their infectivity in humans through multi-generational passage in other organisms. But they still remain similar enough to the human infecting variety to induce active immunity and memory. So that's what it says here under this bullet. Now, these vaccines induce cellular and humoral responses. A big advantage of these vaccines is that they induce strong, sometimes lifelong immunity. But the downside is that it can sometimes revert to an infectious form. So it is often contraindicated in pregnancy and immunodeficiency. However, just because someone is immunodeficient doesn't mean they can't get the vaccine. It depends on the extent of their immunodeficiency. Now, the MMR and varicella vaccines can be given to HIV-positive patients if their CD4 count is greater than or equal to 200. Now, some examples are listed here. There are quite a few. Now, be aware of which type of vaccine, like for polio, and the route of administration, like for the flu vaccine. Now, our mnemonic is, attention teachers, please vaccinate small, beautiful young infants with MMR regularly. I hope it helps. Now, next up, we have the killed or inactivated vaccines. They make use of viral particles that have been rendered non-infectious through exposure to heat or chemicals, though it can still induce an active immune response because epitopes remain intact, and this response is mainly humoral. The advantage to these vaccines are that they are safer than the live vaccines, but the downside is that it creates a weaker immune response, and booster shots are usually needed. Now, some examples are listed here. Again, be aware of the route of administration, especially for the flu vaccine, and that the killed polio vaccine has the K in it, the Salk version. Now, our mnemonic for this is a little morbid. It's RIP always, but just for review, I've added these images. Now we've got the bullet shaped of the rabies virus and the cytoplasmic inclusions in rabies. Do you remember what they're called, these cytoplasmic inclusions? Yep, they're Negri bodies. Now, next up, we have the subunit vaccines. As we've been talking about all this antigenic material, subunit vaccines take into consideration that the whole particle isn't needed, just a little bit, the part that stimulates the immune system. Now, the advantage of this is since there's less stuff in the vaccine, there's actually a lower chance of an adverse reaction. However, you can imagine how much goes into just taking the particular subunits that will stimulate the immune response with less chance of adverse reactions. So the disadvantages here are these vaccines are relatively more expensive, and they also produce a weaker immune response. Now, some examples are shown here, and my mnemonic for it is when you take a history and physical, or an H&P for short, you get the blood pressure or BP, and systolic comes first. So HNP, SBP. Now, here are some images. Can you identify them? So the first one is showing an encapsulated bacteria, and it's pointing to the capsule. This is actually strep pneumo. The second one is showing you a very, very cherry red epiglottis. So this is epiglottitis on endoscopy from H. influenza. And finally, we can see some diplococci hanging out intracellularly. So this is Neisseria. Now, so since we're talking about some encapsulated bacteria like Haemophilus influenza type B, Neisseria, and strep pneumo, this is a great time to mention that some vaccines that have polysaccharide capsule antigens get conjugated to a carrier protein. Now, how come? It enhances immunogenicity by promoting T-cell activation and class switching, since a polysaccharide antigen by itself can't be presented to T-cells. Now, of the pneumococcal vaccines, PCV13 is the pneumococcal conjugate vaccine, and PPSV23 is the pneumococcal polysaccharide vaccine with no conjugated protein. Both the H. influenza type B and meningococcal vaccines are conjugate vaccines. Okay, lastly, we have toxoid vaccines. These vaccines have a bacterial toxin that is denatured, but it still has an intact receptor binding site. So it can still stimulate the immune system to make antibodies without potential for causing disease. The advantages here are that these vaccines can protect against bacterial toxins, but the disadvantages are that the antitoxin levels may decrease with time, and so then this is going to require a booster. Now, some examples are the tetanus and diphtheria vaccines, and in this image we can see pseudomembranous pharyngitis, that gray-white membrane, and this is in diphtheria. All right, that's all I have for you here. Please give this video a thumbs up if you liked it, and it will give you the opportunity to submit a comment if you have any feedback or questions. Thanks for joining me. Study hard.